FAVMI presents Unfolding Mental Illness, hosted by Saraswati Suresh.
Welcome to Unfolding Mental Illness, a podcast by FAVMI, a family's voice on mental illness, where we bring conversations that inform, inspire, and create hope around mental illness. We're also the Western Zone of Families Alliance on Mental Illness, Face Me India, founded by Dr. Nirmala Srinivasan. I am Saraswati Suresh, and with me is Dr. Sachin Ganokar. Together, as family carers and advocates, we understand the challenges, questions, and hope to bring about resilience that families need when supporting a loved one with mental illness. And in today's episode, we're exploring Tele-MANAS, India's national telemental health initiative that is making mental health support more accessible, timely, and inclusive through the power of technology. And to have this conversation with us, we are honored to welcome Dr. Swati Ravindran, Assistant Professor of Psychiatry at NIMHANS, and who is closely associated with the National Tele-MANAS Project. She's been at the forefront of strengthening this important initiative, helping expand access to mental health support across India through compassionate, confidential, and timely care. So let's begin this meaningful conversation. Welcome on board, Dr. Swati. It's a pleasure to have you with us today.
Thank you so much, ma'am, for having me here. It's indeed an honor to join FAVMI today for this podcast. I hope that we can have a wonderful discussion around mental health. And I hope to learn a lot from you as well to take this initiative forward. It's our initiative, it's the people's initiative. So I'd love to get some insights from FAVMI as well. Thank you for having me.
Yeah. So the first thing is, what is Tele-MANAS, and how did it start? Basically, let's start with the basics so that people understand what is Tele-MANAS.
Yes. So Tele-MANAS stands for the Tele-Mental Health Assistance and Networking Across States. It's, like you rightly pointed out, it's the National Tele-Mental Health Program of India. This initiative was started on 10th October 2022, which is the World Mental Health Day. That's the day it was officially rolled out. And the program actually came in the aftermath of the COVID pandemic, in that the COVID pandemic is one time when there was a lot of, there was a lot of focus on mental health all of a sudden, because it was suddenly not a problem restricted to a specific group. Usually what we see with mental health is people are very quick to remove themselves when talking about mental health. There's so much stigma that, oh, this is not something which relates to me or something which I am personally going through. So it's easier to not talk about it. But during the COVID pandemic, it suddenly became an everybody problem. And at the time, we had the National Psychosocial Support Helpline, which was run by the Ministry of Health and Family Welfare and operationalized by NIMHANS. And that service had received around 6 lakh calls during the time. And it was only during the COVID years. And that really pushed the government as well to take cognizance of the fact that digital mental health initiatives can come to use when trying to address a population en masse. One more thing that had really pushed for Tele-MANAS to come about, Tele-MANAS is also the digital arm of the National Mental Health Program. So was the necessity to have a digital initiative given the dearth of mental health resources in India. So because the mental health resources currently, if I'm not wrong, the numbers are currently around 13,000 psychiatrists as on 2026. The number of clinical psychologists may be somewhere hovering around 5,000 to 6,000. Fewer psychiatric social workers. So we are catering to a huge population with very limited numbers. So leveraging technology became almost a necessity at the time. And that is pretty much what led the government to come up with Tele-MANAS as an initiative. Since then, Tele-MANAS has now been working functional for 3 years, over 3 years, and we have received around 36 lakh calls. Yes, so just a background of how it came about and where we are right now.
That's amazing. The 36 lakhs calls you're catering to itself calls a kind of, reach it has already made, and how many people are calling Telemanas, which is the number is 14416
Yes, yes.
for the viewers to, if they want to call up Telemanas, they just have to dial 14416. So anybody can call Telemanas, or is it the person only who is in need, or even a family or a caregiver? So what is the process basically?
Yes, ma'am. So I'm
How
glad
do you
you
go
asked
about
me
it?
that. I'm
Yeah.
glad you asked me that. So Telemanas, like you said, it's a toll-free number. The idea around building a toll-free number is that to improve access, to make sure that everybody can reach it. You can reach it either from a feature phone or from a smartphone. And it's as simple as dialing 14416 any time of day or night. What one can expect is that when you dial Telemanas, you will reach a message which plays in both English and Hindi, telling you what Telemanas is briefly, followed by an option regarding language, your choice of language, your choice of state. I'm sorry, is this bothering you? I'm really sorry about this.
No, there is some element of
Disturbance. I'm hoping it's not very. If it does bother you, please let me know.
yeah. It's
Yes.
as of now, it's not
Sure.
not too loud. Yeah,
All
but
right. Okay.
yeah, continue.
So, Telemanas currently allows you to select your language as well as your state. So, there are some states which are very close to each other, and you may be calling from a border area. So, just to be sure, it helps you choose your state and language, and then you're put on a queue to connect with the Telemanas counselor. Usually, this wait time is in seconds, it is not in minutes, but it varies across states, time of day, the number of call influx at that particular given second. And the very next available counselor in that state is assigned to you. So, how Telemanas works, I just give you an idea when you said that we've catered to 36 lakh calls. We have a network, a system across India. So Telemanas is functional in all 36 states. It functions through 53 Telemanas cells. So we have like the basic unit, how we study in science, the basic unit is the cell. So we have a Telemanas cell. A Telemanas cell is the functioning unit of Telemanas, where we have around 10 to 20 counselors. So any state can have 1 to 4 Telemanas cells, and these cells are spread across India. So, just to have an idea, the bigger states such as UP may have 4 Telemanas cells, Maharashtra has 4 Telemanas cells, smaller states like Goa, Union Territories, Lakshadweep may have 1 Telemanas cell depending on the size of the state and the population it caters to. So, the staffing also is according to the same. And this ensures that the 36 lakh calls, so we have around 5,000, we were around 5 to 6,000 calls a day now. So it ensures that all the calls are answered and not a lot are missed in the process. Yes. I'm not able to hear you, ma'am.
Sorry. So can only the person with needing help at that time can call, or is it even a family or a caregiver can call?
Okay. To answer your question, anybody can reach out to Telemanas. Anybody at any time, either the person themselves who are going through any distress or any suffering, or it may be someone you care for. Someone you care for can be in your family, it could be your friends, it could even be someone you've just seen on the road who may be struggling with their mental health and you want help for them. So we even get calls from the general public around individuals who may be looking as though they are struggling with their mental health and what to do.
Okay. So as you mentioned, anybody could call Telemanas. It could be a family, also it could be a person who seeks help. So
Yes.
how does the counselor then decide how to classify this as mild,
Yes.
moderate, or whether he needs immediate attention? And what is a follow-up after that? I've called, I've done, is the job over? What happens next?
Yes. So, with regard to how a counselor enters information, this counselor actually has a screen in front of them where they enter all this information, starting right from who has called, what is their identity, how are they related to the caller, are they calling for themselves or are they a caregiver, are they somebody from the general public, are they a healthcare worker? So we also have the provision of ASHA workers, primary healthcare workers who may reach out for the service, say for a village. All of them may not have phones. So the ASHA worker then becomes the one point contact for that village. So that is another thing which is happening in many states. And the counselor, based on this information given, they have a performa which they fill, they have complaints which they fill, they have a call classification, and how they know whether a certain call, it may be an emergency, it may be regarding a routine mental health concern, it may even be about an emergency, it may even be about information or even a prank call. So we have these categorizations. Many of these categorizations have come from a detailed review of how helplines function, how we had our previous knowledge about running the COVID psychosocial support helpline, and what all we could do to improve it. So, from the time of its inception, this screen also has undergone multiple rounds of vetting just to ensure that we are in tune with the latest concerns or to ensure that the counselors have the maximum information possible. I would like to mention here that Telemanas does not record calls. So when you're calling Telemanas, neither the counselor nor the mental health professional has information regarding your phone number. You are free to not let us know your name or your demographic details. That is your choice. So if somebody is reaching out to the service, we do have that option where we say prefer not to say. So an individual may choose not to disclose their details. That also happens frequently. But as much as possible, we do encourage, we let them know that we do not have access to their phone number, that their information will remain confidential. Telemanas is in line with the DPDP Act. So in that sense, we can ensure that the care that we are providing remains confidential. That is a justified and valid concern, and everybody is right. So that's something that's on us, and we have to very much ensure that. With regard to whether a call is an emergency or a routine concern or information, there is a detailed training process. So Telemanas counselors, we've trained around 2,000 plus counselors, including DMHP. Currently, we have a workforce around 690 counselors. And these counselors are trained through a 50-hour training process. Right at the outset, they have an onboarding online training followed by an on-site training where our team from NIMHANS, team from NIMHANS travels across India and make sure that, we have a hands-on skill-based training. We also have a basic accreditation for these counselors. They undergo an accreditation course over 3 months, which there is a lot of personal handholding by the mentors, both at the mentoring institutes as well as at the epics.
So based on that, they decide how to take it forward.
Yes. Based on that, they are trained to understand what a mental health concern may be. Is it an emergency call? Is it a routine mental health concern? Could this concern be a symptom of an underlying illness? When should I consider escalating it to a mental health professional? They are not free to diagnose. We do not say that they should diagnose at all. That is only under the purview of the psychiatrist, and we limit it to that. Many a times, the psychiatrists themselves may refrain from diagnosing if the person requires a further evaluation before coming to a conclusion. We may only have a provisional impression at the time. So that becomes very important.
So at what time, sorry, continue.
No, I just wanted, if it's all right, I explained to you regarding the Telemanas cells. Yeah. But I also wanted to tell you that as these cells are spread across, we also have 23 mentoring institutes across India, which mentor these cells. And these mentoring institutes are further supported by regional coordinating centers that are 5 in number. These are all centers of excellence. We have PGI Chandigarh, IBHAS, Central Institute of Psychiatry, Ranchi, LGBRIMH, and NIMHANS itself. And finally, we have NIMHANS, which is the Apex Coordinating Center, of which I am a part. So it's a very structured system which allows for multiple checks and balances, really, to ensure that the system works smoothly.
Okay. So you mentioned that they refer to the psychiatrist. Somewhere you mentioned, at what point do they then refer to the psychiatrist?
Right. So this may actually vary from case to case. For instance, if a caller calls in grave distress, they have communicated to the counselor that they feel as though they're wanting to end their life. At the time, they would provide psychological first aid. The counselor is not, okay, wait, let me just transfer the call to a psychiatrist.
Correct.
It's not like that, because then also that immediate 5 minutes, even much of what is done by 911 or all these international crisis support helplines, it comes into focus as to how our counselor is interacting in the first few minutes of the call as well.
Okay.
Secondly, once the counselor recognizes that this could be a symptom of an underlying illness, or the person at the outset, right at the outset, they state that I am having a problem with my medication. I'm already diagnosed with XYZ and I am undergoing treatment at this hospital. I have a doubt regarding this. So that is a question only a psychiatrist can answer. So in those cases where the person may already be taking treatment, the person may already be diagnosed with a certain illness, whether that is true or not, we don't leave it to the counselor to decide or to go further regarding clarifying side effects of medication. That is something beyond their purview.
Correct.
So we ask that they transfer the call to a psychiatrist and they will take it forward.
Okay, so they'll transfer the call. So what happens? You also mentioned about suicidal thoughts.
Yes.
What happens? I mean, they talk to the person for the first couple of minutes, and then do they again transfer the call to the psychiatrist?
So usually with suicidal calls, if there is an immediate suicidal risk, we first have to identify whether there is an immediate suicidal risk. And instances where that's happened, the call usually lasts longer. It is longer than an average telemanas call. And our counselors are encouraged to engage for as long as possible, as necessary, as important to the individual at that point in time. It could be 5 minutes, it could be 45 minutes, but our counselors are encouraged to not break that chain. What happens is sometimes the moment when you say, I'm transferring the call, they take it as a personal aggrieving that, oh, you don't want to talk to me, or why are you giving it to somebody else? I just got comfortable talking to you. So keeping all these nuances in mind, especially since a rapport is developed, sometimes the counselor remains on call while encouraging the person to speak to a psychiatrist.
Correct.
Just to ensure. Now, one thing I'd like to be very clear about is that psychiatric emergencies cannot be handled over the phone, and we do not encourage their sole handling over the phone, meaning that telemanas acts as a bridge to existing mental health services at the time. So how we act as a bridge depends on the circumstances of the individual at the time. Do they have somebody near them? How much of a risk are they at the time? Are they willing to take help? If they do not have anybody near them, they are in a place where they may be in a dangerous situation.
Correct.
So they perhaps, even we have gotten calls where people maybe just calling us to inform, hey, I wanted somebody to know that I was here. There are even calls like that. So being mindful of their current mental health state, telemanas then has to very quickly discern who is required right now. Is it the police? Is it the nearest mental health hospital? So we have to liaise with, say, the ambulance services or the police or the hospital in the nearest place, and to ensure that this person is taken for help at the earliest. So it can include informing the CMO, so the casualty medical officer at the nearest hospital, letting them know that XYZ has called, they're at immediate risk, please ensure that they are seen and catered to. So it may be a one-line communication, but at least that person will know that this patient is expected. This person has never been seen before. They are very, very distressed. Sometimes this is not just a psychiatrist or a mental health professional's job. That is also something which we have to be mindful of. We have to be in the know about the laws of our country. And when somebody is in acute distress and there is significant suicidal risk and they are alone, the only emergency response team which is authorized to help at the time is the police. And they have been so we have these sensitization programs. The police has also has been very, very helpful, I would say, in these situations where they are aware of what telemanas is and they actually go. within a few minutes. And those few minutes can make a lifetime of a difference in the person's
So the
life.
counselor then liaises with all these people, and your system basically takes care of the entire thing.
The counselor liaises with the mental health professional. The mental health professional is usually the one
One who
doing all
takes.
this coordination. Yes.
Okay, okay. So, what about families? Do you all have families calling up, saying that, the person at home is not responding to seek treatment or refusing to take medications? What are the kind of common concerns actually do you all normally get on telemanas?
Right. I actually, I was just going through this because, of course, we do get calls from caregivers, but nearly 12% of the calls that we get are from caregivers, and around 85% are people who call for their own distress, but 12% are from caregivers. Many of the times it's the spouse or it's a first degree relative who is calling.
Correct.
And the concerns, they vary from, say, sleep disturbances, sadness of mood really comes across as the main reason why caregivers are calling. So caregiver calls are those when they're calling regarding a family member. Of course, they can call for themselves also, but
Correct.
this is specific calls when they're calling regarding a loved one. So those calls, sadness of mood, anxiety, sleep disturbances, violence, aggression, even suicidal risk are some of the reasons where caregivers have reached out to the service and sought help.
Okay, okay. That's interesting to know. That's quite a big percentage of 12% which are
Yeah.
reaching out to telemanas. And I'm hopeful that through this podcast, we are also being able to spread this message that if families need support, they can reach out to, the toll-free number of 14416 of telemanas. So is this process across states same, or is it different among states? Just like you said, of course, people could choose the language. Besides that, is there anything which is different? Something which happens in Maharashtra and something which happens in Madhya Pradesh or Uttar Pradesh, or is it just the same, which is being put across by NIMHANS?
So the basic structure of the program does remain the same. How these cells are operationalized, some initiatives, integration at a state level, because Telemanas right now, the functioning of the state cells is very much under the NHM. It is taken care of by the state government. So the state government does play a major role, whether it comes to awareness activities, liaison with existing state helplines, using Telemanas as a resource for other health programs. It could be, say, NACO or the TB program. Individuals who are, struggling with certain health ailments and may also require psychological support. So those initiatives, in some states, I think liaison with emergency services is underway, where Telemanas also becomes the mental health arm of liaising with emergency services. In some states, I think the wandering mentally ill. So the awareness around 104. I think it's Tamil Nadu, I believe, where the information from the general public regarding wandering mentally ill is very, very well. It's a very well curated system, and they liaise with Telemanas and ensure that this person is brought to care. So there have been a multitude of learnings across states, I would say. Of course, I don't want to present it as a rosy bed. Of course, there are challenges as well. There can be geographical challenges sometimes that we encounter since it's a telemental health service, connectivity, say the Himalayan regions, or when we're talking about the northeast of India, there are certain times of the day and certain, restrictions, security reasons, which, we have to be very mindful of when running the service. And there can be breaches because I've called, sir mentioned about a trek. So I was on a trek when I called Telemanas from a mountaintop. It did connect in Uttarakhand. And so that's what happens really, that you can have, it was breaking. So I was like, okay, connectivity is an issue at this point in time. So people who are trying to reach from, and it should be accessible, of course. So that became an action point for us, for our technology arm, to just work around or to communicate with the Ministry of Health and Family Welfare, which again communicates with sister ministries to just ensure that the service runs okay.
Okay, yeah. I'll now hand it over to Dr. Sachin to take forward for further questions. Yeah.
Thank you, Saraswati. Thank you, Dr. Swati. I think thank you for taking us through how did it start, how do you actually triage people, and what is the process, and actually explaining us in such a lucid and in a very comprehensive manner. Just to take it forward, we just wanted to understand, is the service available in different languages across all parts of India? Also, is the same service available across states, which you have already mentioned?
Yes.
Is it available in different languages across all parts of India?
Yes. So to answer your question, yes and yes to both. It is available across all states and it's available in 20 languages. The Telemanas app, which is we have it on Android and on iOS. It's primarily a mental health educational tool. So for people to understand, that also is available in 12 regional languages right now. We are expanding it and hoping to bring it to 20 sometime soon. So the service, when you call 14416, it is available in 20 languages. These 20 languages are actually distributed across India in that every state may have the option of, say, 3 to 5 languages. Some states may only want English and Hindi. Some states may want their regional language first because that is the major population that's, calling in the regional language. They should understand the message enough to be able to press something. So we ensure that preference is given to the state as to which languages they want and how many languages they want. So usually it varies from 3 to 5 languages per state.
Yeah, thank you, doctor. Who are the professionals handling the calls? Psychologists, psychiatrists, trained counselors, and what is their training?
Right. So the counselors that we have, so primarily we have a two-tier system. We have the first tier comprising of counselors. So those are the 690 that I mentioned in force right now that we have across states. Counselors are either bachelors or masters in psychology or social work. That's their minimum qualification to be able to be a Telemanas counselor. We have the second tier. So when I speak in a Telemanas cell, there may be 10 to 20 counselors and 4 mental health professionals alongside these counselors, 4 to 5 mental health professionals. These include psychiatric social workers. So they'll have an additional, after their masters, they'll have an additional MPhil in psychiatric social work. Clinical psychologists. So they have, in addition to masters in psychology, they'll have an MPhil in clinical psychology. Then you have the psychiatrists who are MBBS and MD in psychiatry. So we have it's built in a way that we have the expertise. We also have psychiatric nurses who have a specialization in psychiatric training specifically. So MSc and followed by a specialized training in psychiatric nursing. So those are the mental health professionals which we have across states. Not all states have all 4 types of mental health professionals. It also depends on the recruitment and how many came in. But at a minimum, the attempt is to always have a senior consultant psychiatrist, a couple of senior residents, so that's the consultant psychiatrist level, and 3 mental health professionals who may be clinical psychologists, psychiatric social workers, or psychiatric nurses. So the escalations are taken by the mental health professionals. The first line is always handled by the counselors. With regard to their training, like I mentioned, we have 50 hours of training. All Telemanas counselors are expected to go through these 50 hours. Starting from, so before they take calls, we have this online training, which they absolutely have to undergo. It's a 3-day training program. Once they undergo the 3-day online training, which we actually have this online training in a rolling format, in that we have it nearly every week since the program started. It's our own team that takes it. As soon as a new counselor joins in a state, we have this training for them. Even if it's one person, we have this training because we have to ensure that service is provided without any lapses in judgment or training needs. So the online training is the first component. This is followed by an on-site training component. So where the team from NIMHANS, along with the team at the mentoring institutes, so these 23 mentoring institutes that I told you and the regional coordinating centers, so all of us professionals come together to train the counselors of that particular state. So the training team may be anywhere from, I think, 5 to 20 that we train at a time. This is also a detailed, 20-hour training. So we have like 3-day on-site training where we have a very hands-on what is exactly counseling, what to do, what not to do. How do you actually transfer skills to a counselor is by actually showing them how it may be done, by having role plays, doing that live, making them do that. Sometimes replaying very challenging situations. We have a session on challenging calls where we discuss legal concerns. We discuss calls from vulnerable groups like the LGBTQI community. We may have calls from aggrieved individuals who don't feel like they've gotten help. So we need to be able to help come what may. We cannot refuse help. So those are the challenges which we try to take more hands-on in the on-site training. This is followed by a self-paced learning course. So they have a basic accreditation course. All this is part of that. These are requirements to be able to get certified. So we have a basic accreditation course for Tele-MANAS counselors, which is under the NIMHANS Board of Studies. And counselors across India are undergoing that course. And over a period of 3 months, once they finish their online on-site, once they've finished these self-paced modules, we also have test calls as part of this accreditation process where we simulate real life situations. And to the counselor, it's a live call. And how they answer decides whether they get certified or not.
Oh, thank you, doctor. That was very comprehensive. Just wanted to understand whether it's 24/7 and what are the efforts being made to ensure accessibility for people with disabilities. One who cannot hear, one who has visual disabilities, and one who have cognitive disabilities.
Right. So, yes, the service is available 24/7. Of course, like I said, the service belongs to the people, and by people, I include all groups, all vulnerabilities, irrespective of the disability they have. For individuals with visual disabilities, of course, many of the phones itself have the braille connotations and they are able to dial and access the service. However, individuals with hearing disabilities is something we're working on very actively to ensure that we can have a setup where it may not be a traditional audio call, of course, but it may be a system in which they are able to access the same resources. This is not as easy, I would say. We are in the processes of building this. And we hope that either through the medium of the app or the website or through a visual source, we are able to cater very in a way that they need. We are able to cater to the individuals with hearing disabilities as well. With regard to cognitive disabilities, I believe many of the calls that we may be getting may be from caregivers, especially around parents of children who may be struggling. So it's usually caregiver calls. And of course, sometimes the counselor, this may not be something which may be handled at a counselor level. The call is usually escalated to a mental health professionals, and more nuanced support is provided by the mental health professional in that case.
Thank you, doctor. How do counselors and professionals themselves cope up with emotional distress, heard, and learn to unwind themselves?
Right. Thank you for asking that, actually. That's a very important question because I think mental health professionals are people and we also go through similar cycles of, all the emotions, including feeling overwhelmed, feeling burnt out, feeling sad, feeling anxious, feeling, some of us may be struggling with mental illnesses ourselves. So I think from the outset, our attempt at Tele-MANAS was to have a very inclusive approach, even for the employees of Tele-MANAS. So well-being activities is one thing which has been a core part of our training itself. So all these trainings that I told you about, we have a well-being component. Starting from the on-site where we end every day with a well-being program. What these well-being programs also do is to let the core team at the Tele-MANAS cell know how to do this in the future. Also to have programs aimed at, de-stressing or debriefing. It can also be sometimes a debrief at the end of the day with the mental health professional, which we encourage on a weekly basis. We tell the Tele-MANAS cells to always have a conversation. It's not necessarily limited to once a week. Sometimes, depending on the nature of calls, this may be much more frequent than that. I'll give you a small instance which was shared by a Tele-MANAS counselor with me during one of the trainings. And it also provides a very candid insight into how, our frontline workers are actually warriors, I say, frontline warriors are actually facing these challenges head on. Something as common as grief, getting a call from somebody who's lost a parent while going through grief yourself of losing a parent. And the counselor was in a very vulnerable state. She did let me know that she did not lose face. She told me, I'm quoting her verbatim, that she did not lose face and she did handle it, but she was a mess afterwards. And she did not, she took some time to come back. So it's also letting them know that that's all right. It's all right to take that breather, take that space before you address the next call, because the emotional weight or the emotional toll of doing a shift based job in mental health may not be the same as other services. The nature of calls, the weight of it may end up taking a toll on them. So we have these debrief sessions. We also tell them how to navigate these more challenging situations. It may seem very common. It may seem like, okay, everybody goes through this, or it may seem, but we try our best to validate their concerns. We try to ensure that they have a peer support system, that they themselves have almost like a buddy system within themselves. These are also in line with the, so Telemanas has undergone multiple evaluations. So starting with WHO, which had a rapid assessment report on Telemanas. And these were some of the recommendations from that report, which we try to incorporate in every training and in the Telemanas cells, right to the top. So this also happens in mentoring institutes. We also try to follow the same at the Apex Institute also. I think every few months we have our clinical psychologist who arranges these well-being programs for the 20-30 of us and ensures that everybody gets a breather.
And that's great to listen. I think that's you also need to do self-care. So that's very nice to actually see that this process is in place. What are the most common concerns families bring to the helpline? Many people hesitate to seek help because of the stigma or fear. And we know that early intervention is very important. So how can a home-based service after COVID especially make it easier for them to take the first step and prevent the problem from becoming more serious?
Right. So I think can I start with the third question? In which case, so something which makes Telemanas slightly different from existing mental health resources is that accessibility at the tip of your fingertips, right? So you can just pick up your phone, dial 14416. You needn't go to the next room. You needn't tell anyone about it. You needn't think too much also. You may not have to access your resources or waste resources. There is no out of pocket expenditure. And most definitely, I think the stigma around going to a psychiatrist or going to a mental health professional and people finding out or people knowing that you have a file in a mental hospital, sometimes all those things are what add up to the existing distress of the individual. So Telemanas takes care of that outside of the individual themselves who is calling the service, apart from very rare instances, of course, but even in suicidal individuals, we try our best to make sure that they are in the loop about what's going to happen. But in very rare instances, if at all, we've yet to encounter it, but if at all a legal, from a legal standpoint, a court orders it or otherwise, information is never ever shared. It's never shared with the individual's personal details or their name or their phone number, or those are details which are absolutely disguised. It's disguised at multiple levels, so it's not even us at NIMHANS who can access it. We have a strict unmasking policy. We have a strict SOP about how to handle emergency calls, how to handle prank calls, when to block. Very rare, again, about prank callers who may be threatening our counselors, say with aggressive threats, or they found out about counselors' personal information. So we also have to protect. So all these policies help in ensuring that we are able to do justice to the caller. Preventing stigma, I think what you said about, I think the answer was in the question itself, the fact that they can access it from their homes and the fact that they don't really have to ask somebody, tell somebody, rely on someone outside of the phone. So sometimes the phone may also not be their own, is what we've realized. So we have to wait. There may be instances where the person may be in danger. There may be instances where the person is a victim of abuse. and we don't call back without consent. Unless it's an emergency with regard to suicide, we know the person's at risk, the person has the phone. It's a situation of abuse. We are mindful of letting the person reach out, letting them know that they can reach out anytime. So I think these are the myriad of challenges that we really face when it comes to what makes a difference, and how does Telemanas really bridge that gap with regard. So the gap really comes from the difference in work, like the workforce, a definite lack of workforce. I think I'm not sure if in my lifetime that lack could be compensated with our current population, whether it could come to the WHO recommended standards of one per lakh, but uh, you know just ensuring that you have technology to bridge that gap, or you have something connecting you to an existing resource, makes a world of difference. Knowing that there is an option, we do not want to market ourselves as a service which you should always reach out to or always have, but have it in the back of your mind, have it somewhere, have this knowledge somewhere that a service like this exists. When required, when you're feeling distressed, please reach out. You let us know. I think you asked a question regarding follow up, right?
Yes, in
Have you?
fact, I wanted to
Yes.
re-ask
Yes,
you that,
yes. So,
because you all don't store numbers,
yes.
and early intervention is the biggest, process which one recommends. How do you then ensure that the person has gone and, he's feeling better even after a few days?
So I think what makes a difference there is that we have a Telemanas ID. We recognize the individual by the Telemanas ID. A Telemanas ID is unique to the person. It is not a number which can be easily called out or replicated, but it helps the Telemanas counselor and the MHP know who to call back from that number, from that list. Also, we can schedule follow-up calls. We can schedule callbacks with the individual at the time of ending the first call itself. So we take due consent from the person. Do I have your consent to call you back? Can we mutually decide when we want to schedule that call back? Do you want to have, say, I'm in office all day, so I can only take your call from 9 to 10 p.m. Can you call me back then? Yes, of course. So it may not be this specific counselor because they're on shift jobs. There are 3 shifts. So the counselor who's available in that particular shift calls this individual back. And if the case is such that the individual feels that they want to follow up with the same counselor, or the counselor also wishes to continue, say, the second session or the third session of speaking to this person, building a rapport, then they can schedule a call back during their shift at a time that they are available. The only instance where consent does not matter for follow up is suicidality, where the risk to life is so much that we do ensure that we keep reaching out to the, say they've cut the call, they've just said that they want to die and they cut the call. We keep calling back to ensure that we're in touch. They do sometimes pick up. So that's enough for us to keep engaging with them, say till the police reaches, or say till they sometimes, just like, okay, I'll be on call. Why don't you go to this place? Can you physically go there and I'll just be on call with you? So that's something which Telemanas can do. In those ways is what I believe we are bridging, or we are being that resource which may otherwise not be possible if it was not for a digital mental health service.
Thank you, Doctor. That was a wonderful explanation. So, what could be the most common concerns families bring about? Is it relationships? Is it like
Yes.
acute distress? Is it exams? Is it something like a fight or addiction? What are the most common concerns you see based on data?
So I think the most common concern that we have regarding calls about a person in distress from caregivers happens to be sleep disturbances. This is very much in line with what even people who are calling for their own sleep disturbance. Sleep disturbances happens to be a very common complaint. It's always been in the top 3 complaints. So that also continues for caregivers. Substance use also happens to be another very common concern. And understandably so. Like I said, the most common calls from caregivers happens to be from the spouse. So in substance use particularly, I think the degree of distress faced by the spouse, the family, is directly in proportion to maybe the substance use, or maybe exponentially higher. So many times those are the calls we receive. There are calls regarding violence or aggression. So that's another concern which I think I've had multiple discussions with Nirmala Srinivasanji also regarding the same. And it's a very, very valid, very pertinent question that we have to answer regarding how to bring individuals. And we are working in that regard. That's where I said the liaison with the emergency services really puts because telemanas by itself we are available digitally, but how do we actually help the individual? So that's where, liaison, sometimes even explaining to the ambulance driver or say explaining to the police personnel, ki, this is how you handle, please speak to the caregiver, please let us speak to the caregiver. So those are the ways in which this triangulation of emergency services may be helpful. So of course health is a state subject, much like law enforcement, and so that this is a process. It will take time before all these triangulations and all these intersectoral collaborations really happen across India, but it is a start. From our experience, we have a lot of success stories where suicidal individuals have been helped or have managed to reach health services in time. Another thing I'd like to highlight is that we, like I mentioned, we are the digital arm of the DMHP. So the district mental health program also travels in many states. They come to the home of the individual to ensure that the person receives care. This is not true for psychiatric emergencies. Like I said, even by law, they are supposed to be taken to a hospital. But say for an individual who has a case comes to mind where a person was ostracized and the family was ostracized and actually not part of the village anymore. And the DMHP managed to travel, get the person to care, ensure that the family who was also, suffering from physical disabilities, they were given access to the right governmental schemes. They were helped. There were education programs which were run for the village, for the sarpanch of the village, to ensure that they know that this is a mental health issue. It can be treated, and if this person is in treatment, he's very much, he's part of your village. He's not supposed to be thrown out, or he's just because they're going through these symptoms, they're not supposed to be treated differently. All that is where Telemanas and DMHP lies with each other, and also what it becomes an education tool for Telemanas. So one wonderful thing that happens, especially in our rural communities, is that the community sort of comes together to care for the individual. So that's what was happening in that particular family's case, that they actually got together and became like a community project to ensure that this person stays, takes his medication on time. And he's very much been in touch with Telemanas even now. And it's a well-being check, which they themselves call and let us know they're doing okay. And we continue to do that. We continue to remain in touch with them. The discretion of till when and how when depends a lot on case to case.
Thank you, Doctor. Doctor, you mentioned initially that in 3 years you have received 36 lakh calls. What based on your experience has been the response to Telemanas and the impact, and what are the future plans of expansion with Telemanas? What role can Telemanas play in shaping India's broader mental health policy?
Right. So yes, Telemanas, I think we are at 36 lakh calls right now. I think there has been an exponential rise in the calls as I think it was initially, it took about a month, then it became like lesser, 15 days, then it became 10 days. So every lakh, the numbers would escalate. At the same time, there's a question of capacity and how much capacity can the service handle. So we are definitely not anywhere near peaking, and we can handle a lot more calls. We are also hoping whether how much of an impact it creates is, I think, something which we have to wait and watch, really. We have to wait for, say, another 5 years. We have to conduct a lot of implementation research, which we're doing right now. We're in the process of doing that to understand really health trends, call trends, the nature of individuals who were in distress, who were helped, where were the lacunae, what could we have done to improve. And it's not a one-time process. I don't think that we'd have to wait for 5 years, but this is a continual process of looking at the program. So we have these meetings, coordination meetings, both at at the apex level, we have these meetings with the Ministry of Health and Family Welfare, who is very, very closely involved in the functioning of the program. They are the ones who are, who are at the forefront of pushing and ensuring that this initiative actually makes a difference. So the Ministry of Health and Family Welfare also has meetings with all its stakeholders to check on the functioning, to check on the training, to check on the awareness advocacy. It's not just one area of work where I think Telemanas can make a difference. It can be a model, even internationally so, for a mental health initiative at this scale, catering to such a diverse population, with the workforce strength that Telemanas has. I think it is one of the very few, if not the only one in the world to have this kind of model. So, if I would say, I'm putting in a cautionary note that if we succeed, I think it could be a model for the world to follow through. We have had encouraging words from the U.S. Surgeon General at the time, who had visited Telemanas and had also encouraged us that this is something that 988 could also learn from. And those were very encouraging words from him at the time. So this is a continual process, and how we hope to make a difference is through constantly working towards awareness, working alongside also. I'd like to mention that the working alongside NGOs, working alongside, like yourself, working alongside policymakers, working alongside lawmakers, law enforcement agencies. It's only when this program sort of permeates horizontally and vertically that we'll be able to see a difference. Because seeing a tangible difference in stigma, in these things that really translate into actionable points when it comes to a PWMI or their families, I think that's what we should have as a tangible outcome, that this is what we want to change. And this is the effort that happened over years to make that difference. Telemanas is also the result of a lot of change which happened over the years. So we had Indian Lunacy Act in 1918, right? That became the Mental Health Act of 87. That became MHCA 2017, which is strictly a rights-based act, and thankfully so. And then we have the National Mental Health Policy, and slowly that push for community-based care, push for a rights-based approach, push for privacy is what led to all those things have had an impact on the National Mental Health Program, digital arm of DMHP, finally Telemanas. So this is very much a process which is happening. I'm hoping that the efforts for this program continue. That's what I will be hoping for the program to grow as well, that we keep collaborating, keep learning, grievance redressal, feedback, ensuring that we work on the feedback to improve the program is the only way the program will improve, right? So that's my take on it, at least. And I hope that we can come through, and we are always open to suggestions. I always encourage and I always tell people that you have our email ID. Please mail us regarding any suggestions, any experience, because we would like to learn from that and we would like to grow.
Oh no, thank you, doctor. That's quite wonderful to hear, and it's really heartening that this helpline was set up, and actually it's helping a lot of people access some kind of care across the country. Because there is stigma, people do not actually go to a mental health specialist, and I think you need something to actually bridge that gap. Just to take it forward, what do you define by success for Telemanas? What are the metrics you use, like call volume, quality, or TAT, to evaluate your helpline? So, what do you mean by success, and what are you targeting as success, as you mentioned in your conversation, for the helpline to make it better and bigger?
So I think success would be, I would wait for other people to say that it's successful or not. But with regard to when I say success stories, I'm referring to the life of one individual where Telemanas has been able to make an impact. So these are verbatim scripts. So either as audios, videos, there are many people writing in to also tell us that Telemanas has made a difference in their life. And that's how we know about this tangible change that's come about, thanks to the individual reaching out to the service in time. You spoke about early intervention. I think that does, we've seen what happens when that actually is able to come to pass, or the person actually reached out and a situation did not get worse. With regard to quality of the call, so we have a quality assurance process here. Of course, the training itself is, like I mentioned, it's like long-standing, and we are in touch with these counselors. We all have state in charges. So there are 20 odd mental health professionals in the Apex. Each of us have a few states. We all are in very close liaison with what's happening in those states and what's happening with the counselors of that state, the calls of that state. But we are also in the process of digitizing a lot of the quality assurance indices in a way that whatever is being done manually right now. So we have test calls, the platform for test calls. Like I mentioned, the counselors do not know which calls are test calls. We know back end that this call was a test call, but at the outset, we do not inform a counselor that we're going to test them, and because it'll be very performative, right? Or it'll defeat the purpose of how they're speaking, say, at the end of their shift, how they're speaking when they're very upset, how they're speaking in the beginning of their shift. All of it may vary. So based on that test call, we'll have those test calls are recorded, of course. They are not used for any critical assessment, or it's all a feedback process. The counselor is given a lot of chances to improve upon that feedback as well, and we have training in a very personalized manner to ensure that that comes through.
No, thank you, Doctor. This has been a very wonderful conversation, and you have explained it so thoroughly and with so much of enthusiasm that we're very happy to actually like speak to you and understand how Telemanas works. The questions what Saraswati asked about how did it start, how do you triage, uh, what do you actually do in a crisis, and plus I think this entire conversation about the flow, what is the future, and what are the different challenges you feel, and what are you planning actually to take it to make it much better in quality and in performance. So just to come to the last question, and thank you very much for your valuable time. If one listener is today is silently struggling, and there is a shyness or there is inhibition to actually pick up the phone and speak to Telemanas because of various reasons, what message would you like to leave with them?
I think something I'd like everybody to know is that help is really always available. It is accessible. There was a time when all this may have seemed like gung ho. It may have just, felt like it may not work. A lot of our first responses to a lot of programs is that, but it does work. Telemanas is a system. If it does not work for you, please let us know. We'll make sure it works and we make sure we get to you. But I want everybody to know that right now in India in 2026, you can sit at home and you can dial a 5-digit number, you can dial 14416, and you can reach a mental health professional. You can reach help for something you may be struggling with. Your struggle is very real. It is not something which you may want to share with everybody, but this is a safe resource. This is something which we will not go and tell family members, or we may not tell your friends, especially the younger population. I'd like to specifically say this to them. Some of the challenges you're seeing, some of the world events you're seeing, it may be feeling really overwhelming right now. But I just want everybody to know that help is available. And we would really like to try our best to help you the best we can. So right now we can do that through this service. It is available 24/7, so you can call anytime. And if at all, I think Saraswati ji, I can always please share the email ID as well. If at all somebody has anything to share with us, we'll be more than happy to hear and address that. Right. So help is available is one thing I'd like everybody to remember, along with the Telemanas number 14416.
Thank you, Doctor. I think what you put, like what I and Saraswati was thinking also, what you put rightly is that sometimes you would not like to share. We always don't feel like seeking help because you either feel it's either too personal, or either you feel that will the person really get some help or not. So I think people stop at that stage,
Yeah.
and maybe Telemanas actually is a great initiative to when a person really decides, you can just pick up and actually start seeking help. So there's less obstacle to actually move out and go and meet a doctor and travel, and maybe feel a little shy to actually go and seek help. So I think it removes all those obstacles which are there.
I'd
I
also
just wanted
like
to
to
thank you
say
for
here that
yeah.
mental health, like the number of individuals which we have, number of people that we have in India, it's so diverse. The number of problems which we have in India may be equally diverse, just as diverse as us. And not all of them require a psychiatrist. I'm saying this candidly as a psychiatrist, that you don't need to come to a psychiatrist for every mental health problem that you may be facing. But just remember the analogy of a pressure cooker and what happens if you don't give the whistle to a pressure cooker, that the pressure just builds and builds and builds till it becomes something that you can't contain anymore. Our mind and brain is just like that. So please share. That sharing is the whistle of the pressure cooker going. So pretty much you having a conversation, journaling, all these are outlets that prevent that strain, that stress from building up in our mind, affecting our body, affecting our blood pressure, giving us chronic lifestyle illnesses. It's all connected. So it's really important that we do not, firstly, never think of mental health as a silo. Never think that mental health does not, just because my mental health may be suffering, it will not impact my physical health. It absolutely does. And to know that maybe addressing this aspect of your life may make a lot of difference in your other aspects of your life, say in your professional stance, or how you're handling challenges, how you're handling challenges at home, how you're handling challenges at work, how you're handling challenges with your spouse. All these, maybe you will get some resources that help you address the day-to-day challenges of your life better. It may just be distress, but if tackled in time, you may feel a lot better. You may not go through the process of a mental illness itself. If you are struggling with a mental illness, if you are a caregiver of someone struggling with a mental illness, it's very important to know that to be able to help the individual, it's very important that you have the resources to do that, or you have the help to do that. Caring is not a one-time effort. As a psychiatrist, I see a patient for say 1 hour or say 45 minutes in the OPD. For you, it's a continual job. It's a 24/7 responsibility. I won't even say job. It's a 24/7 responsibility, a loving responsibility. It may not be something that feels like a burden. However, if you feel that it's getting too much, or if you feel that you need support in being able to support someone you care for, someone you love, then please reach out to Telemanas. We would love to hear you. We would love to maybe understand and help you better to care for your loved ones. Yeah.
Doctor, just also I quickly wanted to just add that I think it's a very scientific helpline, because just to add that pressure cooker analogy, which you put really well, because normally we go and talk to people. So we might in our culture we might go and talk to an astrologer, or there might be some sadhu baba, or like we have our healers, etc. But we might not get the scientific advice which is necessary when you have the distress level. So I just also want to I was reflecting that it's also a scientific approach. Like instead of getting lost and then coming up at a stage when you are really you already had your strain has really gone very high, or you're really distressed, I think that pressure cooker analogy really works well. So I think it's also a very scientific arm of what NIMHANS or what Government of India or what you are trying to build in for the community.
Yes. I think everything, like you said, everything has a place in its life. I wouldn't, maybe, people reaching out to, say, a spiritual leader or to a faith healer. It comes from a place of feeling helpless
Absolutely.
and not, and
Absolutely.
like you said, the stigma around that may be lesser than coming to a psychiatrist.
Absolutely.
I've
Absolutely.
practiced psychiatry in a place where, the faith healer would direct it to us.
Correct. Correct.
Thankfully so.
Absolutely.
And it's called the Dawa Dua model, really. But
Correct.
the important part is that if even the faith healer knows, they are also part of it. If they know that something like Telemanas exists, they will know where to direct. And spirituality, all these are very important parts of our mental health. It's important to have those aspects as well. When in distress, it's of course, like Sir said, having a professional channel, having a professional way. You've done your bit. Now let us do our bit. Trust us to do our bit, is what I would leave it at.
Absolutely.
So I would say that if you are in distress, reach out to the toll-free number of the Government of India of 14416 and help yourself and try to help others in your family if you're seeking help for them. Thank you very much. Thank you, Dr. Swati, for giving us your time.
Yeah. Thank you, ma'am. Thank you so much for having me. Thank you.
Thank you, doctor. Thank you for your valuable time.